Welcome to Mayo Clinic Q&A. I'm Dr. Sanj Kakar. While many non-essential businesses have closed or suspended business during the COVID-19 pandemic, hospitals have continued to operate and take care of both COVID and non-COVID patients in a safe way. How has Mayo Clinic hospitals navigated the pandemic and kept our patients and staff safe? Joining us to discuss this is Chair of the Hospital Practice at Mayo Clinic, Dr. Robert Cima. Welcome to the program, Dr. Cima.
Thank you for having me.
So back in March, when a lot of the nation, as you knew it, sort of shut down, we still had inpatients at Mayo Clinic recovering from various ailments, etc. How had we managed to take care of these patients in a safe way as we traditionally do here at Mayo Clinic?
Well, fortunately, we had a playbook for this. When the SARS and MERS pandemics started over a decade ago, and then with Ebola, Mayo, in conjunction with the US government, set up a high consequence infectious disease team here. And what that team did was basically look at how would we, Mayo Clinic, operationalize taking care of patients with such diseases. These infectious diseases like Ebola, if we had those patients arrive, how would we isolate, safely take care of them, and also do that safely for our existing patients as well as our staff. So we literally had a playbook that went into activation that included dedicated staff who are trained during the course of the years, despite not having any pandemics, to take care of patients like this. We had a facility that was activated and stood up within 24 to 48 hours over a weekend. Other patients were isolated and taken away from that area. That was going to be a locked unit. And over the first few days where we really thought we had patients in the Midwest that met criteria, those patients were brought by specially trained ambulance crews to St. Mary's Hospital, brought into the isolation rooms. The teams were there. The lab was there. Everything was brought into that facility, so nothing really left that facility without it being completely contained. And that's been our approach. And as we learned more about COVID-19, we were able to adapt and get to the point where we are now, where we have dedicated units with staff that are fully trained in the appropriate use of PPE. They're well educated about the nature of this virus as we know it now. And we've not had any exposures in those areas of our staff related to the care of COVID-19 patients.
That's tremendous to hear. Obviously, having this playbook at hand put you a step ahead, as it were, in trying to get on top of this and having areas isolated for these patients and keeping our other non-COVID patients safe was obviously critical. As the months have elapsed, what have you seen in terms of the hospital practice, in terms of the number of patients coming in that are COVID-19 positive?
It's been really stable in the Midwest. And so we've been running somewhere between 10 to 15 patients in the hospital at any time that are COVID positive. That's been split pretty much between those needing some critical care and many just needing general convalescent support care that they just can't do at home. We haven't really seen a big change in that. And it's unclear as to why we in this region are being spared some of what we've seen on the East Coast and the West Coast. But certainly we're thankful for that. It may also have to do with social distancing and other behaviors that were learned from the early states experience and implemented in our region. So we've been very stable. We've been monitoring patients that are coming into the practice. We're screening everyone. We're asking our staff to screen. And so we've been trying to avoid getting these big bumps in patients coming in, but we're prepared for it if it should happen.
Obviously, with inpatients, they have family members that want to come and visit. What have you been doing there to ensure safety, not only for the patients, the staff, but also the family members?
So initially, basically off of the recommendations of the activities on the East Coast, we closed our hospital down, which is usually one of the first things you need to do in this type of situation is to isolate the vulnerable patients, which are our existing patients in here, the ones that didn't have COVID-19, and also to protect our staff. So we locked down, minimized the number of visitors. Now, certainly we in alignment with our Mayo values, did not feel that we could completely exclude all visitors, as some hospitals have been forced to do. So we did have rare exceptions. We set up a process for that. Those individuals were screened. They were required to be masked. In some cases, they were actually escorted to where they needed to get to, because there may have been some circumstance that we were worried about. They may have been exposed to a COVID positive patient. So we wanted to know exactly where that individual moved through our hospital environment. But as there's been more data about what's going on, as we've moved to staff being masked all the time, now recommending they wear eyewear, we feel that we can loosen that up. And we're actually now, as of today, as a matter of fact, allowing an individual hospitalized patient to have a consistent visitor starting today, so that we know that those patients will actually do better when their families with them. And so we want to do it in a safe environment, and that's what we've been preparing for. So it's taken some time. We have a process put in place where those individuals would be identified. They'll be recorded in the patient's record as being a visitor, so that if something were to happen, we would have the ability to track and identify who that individual was.
That's truly wonderful. Yeah, I'm sure obviously the patients and the family are very grateful for these processes that you've put into place. And as you said, these visitors can be monitored should anything happen. As you know now, we're doing more elective surgeries, and with that brings increased admissions into hospital. How have you and the team set this up now such that we can handle this in a safe way as we open up the practice?
Well, this has been a collaborative effort across the practices, with our surgical practice, the hospital practice, and the outpatient practice, trying to figure out how we can do this safely. The surgical practice really couldn't stop completely. So we needed to guarantee that patients coming in for cancer surgeries were somehow screened appropriately. So there was a process put in place where we did PCR testing on them 5 days before admission, then 48 hours before admission. We also, at one point, were actually doing CT scans of everyone to determine if CT was useful in the early detection of, quote unquote, the asymptomatic phase of a COVID exposure. And we did a study on that and found that it really didn't help. So we were, with just the PCR screening, recommendations to self-isolate. And with that process, we were able to do hundreds of patients without any exposures. There was one patient that did convert in the preoperative phase before they even got to the hospital. Day 5, they were negative. Day 2, they were positive. They were then sent away for self-isolation. So that process has worked. That was done for the urgent emergent cases. We're now extending that as resources and our capabilities have come online to do that for every surgical patient that now comes back to our practice. So they'll be screened with a COVID test. They'll be masked while they're in the hospital as much as possible. All our staff will be masked and will be wearing eyewear in the hospital. So we feel we have a very safe environment to continue caring for COVID and non-COVID patients, which in reality are the vast majority of the patients that we're treating at the Mayo Clinic.
I'm glad you mentioned about the pre-screening. We've learned about that in terms of patients, not only before they actually come to Mayo Clinic, they have telephone calls, etc., go through a questionnaire as a checklist, just to ensure that they haven't messed up sort of the risk criteria. You mentioned about CT scans. That was CT of the chest, is that correct?
That's right. There was some initial reports out of China that certain high-resolution CT scans could actually show very subtle inflammatory changes in the lungs. And we didn't see that, but it's maybe because we just don't have the number of patients that are COVID positive to determine that. So we felt that it was a test that, at least in our environment for our patients, didn't add value. And it often it was difficult to operationalize and also expose patients to unneeded radiation. So since it didn't add value, we made the determination based on the safety for our staff that it was reasonable to exclude that. So that was the rationale for not proceeding with CT scans on every patient. I think it's the one thing I would say is the resilience of our staff. This has been very dynamic, as everyone says. And so we have been learning along with everyone else what to do. And sometimes staff view that as leadership and the teams not knowing what to do, and they're changing course. But what I'd like to say is, yes, that's true. We didn't know. We learned as everyone else did, and we're trying to implement best practices. But the staff has been great at accepting that change, understanding that this week we're saying we can mask. Last week we said we didn't need to mask. It's just because we're learning. The reality is that sometimes scarce resources had to be prioritized. So when we were doing the testing, people were saying, why don't we test every admission? Well, we just didn't have enough tests to test every admission, and we wanted to direct it at patients who we knew were going to be high risk. Surgical patients that were going to get intubated, having surgery and then getting pneumonia 4 days later increases your risk of mortality. So we really wanted to use our resources in a strategic way, but at the same time, always be looking for ways to protect our staff. And they've been very responsive to that. Great ideas have come from our staff. And that's really what has made us successful, I think, during this period is the willingness of our staff to adapt, and just them realizing that this is a difficult time for everyone, and that they're part of the team, a valuable part of the team. And that's why we've been successful in managing this crisis.
Yes, well, that's one thing we've been learning about how our staff truly has stepped up, how the innovation has taken over, and their dedication to our patients is just second to none. We've been talking to Chair of the Hospital Practice at Mayo Clinic, Dr. Robert Cima, about how Mayo Clinic is safely opening up the practice. Dr. Cima, thank you very much for joining us today.
Thank you. Have a good day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all the Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then, click on Podcasts. Thanks for listening and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.